Welcome to Medical Matters Weekly with Dr. Trey Dobson, presented by Southwestern Vermont Healthcare and Catamount Access Television.
Dobson, Chief Medical Officer at Southwestern Vermont Medical Center and an emergency medicine physician with Dartmouth Health. And this is Medical Matters Weekly, a show about the aspects of healthcare that matter to you most. My guest today, I'm so pleased to have, is Dr. Ada Stewart, who is a family physician with Cooperative Health in Columbia, South Carolina, and the board chair of the American Academy of Family Physicians. Ada, welcome to the show.
Thank you so much. Thank you for having me today.
We're excited. We're going to be talking a little bit about Dr. Stewart's background and family medicine in general and what we see in the future. I know people in the audience here are worried about recruiting primary care into our area, as well as all of the rural parts of the country. Let me tell you a little bit about Dr. Stewart's background. She served as the Chief Medical Officer and HIV Specialist at the Richland Community Healthcare Association in Eastover and Columbia, South Carolina from 2003 to 2012. Just her background, she earned her bachelor's degree in pharmacy, which I'm going to ask about, from Ohio Northern University, must have switched into medicine there, earned a medical degree at the Medical College of Ohio. And if you're not familiar with that, that's a great medical school, and completed her family medicine residency training at Palmetto Richland Memorial Hospital in Columbia, and is certified in HIV care from the American Academy of HIV Medicine and as a hospice medical director by the Hospice Medical Director Certification Board. Dr. Stewart, you are quite an accomplished individual.
Thank you. Thank you so very much. And thank you.
So tell us a little bit about where you're from and your background, and then we'll sort of move into the medicine aspect.
All righty. So I am from Cleveland, Ohio, born and reared there in a urban area, actually housing projects there in Cleveland. And I ended up becoming a pharmacist because of the inspiration of an individual that came to our chemistry class when I was in high school. And at that time, I was one of those individuals who enjoyed chemistry and math and wanted to do something that involved people. I had never seen a physician other than going to the emergency room here or there. And then after our chemistry teacher had this wonderful pharmacist who looked like me, who came to our chemistry class, I said, that's what I wanted to do. And so that led me down the path of pharmacy, and I attended Ohio Northern, as you mentioned, in Ada, Ohio, just as my first name, Ada. And after I began working as a pharmacist within Cleveland, I encountered so many patients who, realized that they were missing something as far as healthcare is concerned, prevention. And then within my own family, I lost my mom to breast cancer, which was a late diagnosis, and my dad to heart disease. And after that time, I realized there was something more that I needed to do. Ran across an article while I was working one Sunday. It was a Sunday paper, you know how large they are. And, sometimes they have these full page ads about different topics. And they they had an ad that mentioned a physician who was a family physician who took the holistic approach to medicine, cared for individuals from a spiritual, physical, and mental well-being, really impacted the community, was all about prevention. And at that point, I realized that was my calling. And so from that point on, I ended up taking some courses all over again. I'm much older now. This was about 10 years after I was practicing as a pharmacist, and ended up going and getting accepted into the Medical College of Ohio, and the rest is history. And I, at that time, knew I wanted to do family medicine. And, so many times individuals, they go to medical school and they don't know what they want to do. But for me, I knew that I wanted to be a family physician from the beginning. And every rotation that I had, every experience that I had in medical school really amplified that desire.
That's great. And then you ended up doing residency in Columbia, which is how you ended up.
Yeah, so that's how I ended up in Columbia. I was looking for a warm place, opportunity to actually leave Ohio and just, gain some other valuable experiences elsewhere. My plan actually was to go back there and serve within the inner city in which I grew up. But after I attended residency here in Columbia, I found a new calling, a new group of individuals who I can serve. And I tell you, my family still wonders why I haven't come home yet. And I keep looking at the weather and I say, there is a reason, the weather here and the people have been unbelievable. So I have a new family here in Columbia and very happy. And hopefully my family from Ohio would join me at some point here in Columbia.
Well, I'll have to give a shout out to my friends in Columbia, Julian Adams, Jack Stripling, John Boyd. I'll stop there, but if they're listening, they will hear my shout out. Lots of friends that reside in Columbia or from Columbia. It's a great place to be. It's actually a great place to practice medicine. I have other friends who did their residency training, even in family medicine, I believe, and emergency medicine, and rave about the education. So tell us a little bit. I noticed on your bio there your background in National Health Service Corps. Can you let the audience know about that? This is something that is highly interesting to many people.
Yes. So, the National Health Service Corps is a wonderful opportunity. It gives one a means of helping to support their medical education, either through scholarship or through loan repayment. It's all about service. And service to those communities that are underserved. When I decided to attend medical school, I realized that I wanted to serve, again, the underserved communities, either that community in which I grew up and was raised in, or as I was able to find here in South Carolina, a new community, both urban and rural. And it gave me that opportunity to decrease my loan indebtedness. We talk so much about the cost of medical education, and I was able to lessen that by becoming a scholar. Interesting enough, as a scholar, I ended up working with the Community Health Center, Richland Community Health Center, when I completed my residency to pay back the National Health Service Corps scholarship that I received. I am in the same offices that I began with during that time. So again, showing that commitment to service and to serving those who are underserved. And the National Health Service Corps is a wonderful opportunity for one who is interested in, number one, service to those who are underserved under the marginalized population, and to decrease that financial burden that so many of us end up having by going to medical school.
Sure, and also for the audience here, we've gotten much better in medicine, actually, by actions similar to what Dr. Stewart has taken. But for many years, the only way that the underserved and the marginalized could really receive medical treatment in a way that was non-biased and had the equity required was through programs like this. Most of them were in inner cities. So in the rural areas, we're still quite behind.
Yes, definitely. And it's just, it's something that we really have to address. Healthcare within our rural communities is really imperative. We see the problems with access, and we saw it with the pandemic, the health disparities that were really highlighted through our pandemic, especially in our rural areas, access, transportation. Many are food deserts. Eastover, in which I still work one day every couple months, still is really considered a food desert. The only place that individuals have to get really nutritious foods is, the Dollar General or the corner store or the gas station. The grocery store stores are so far away. And, this is something that we do have to take care of. We do have to recognize that we have an issue with workforce, and especially workforce within, these communities, such as the rural communities, and many urban areas are still considered underserved.
Have you seen progress since you started practice in our ability to take care of marginalized individuals and other resources that have been, frankly, I mean, not intentionally removed, but just not available and accessible to so much of the American population?
Yes, there has been some progress, and we really were able to see this with the pandemic, because so much was unveiled, so many disparities, and we knew that they existed. I knew that we had healthcare disparities and problems with equity as far as rural and urban areas, and marginalized populations. Black, Indigenous, and people of color were really impacted by the problems that we have as far as workforce and having access to healthcare. And so as we are progressing and addressing these very issues, we are seeing some improvement. Are we there yet? No, we are not there yet. We have a long way to go. Programs such as the National Health Service Corps that, bring clinicians to areas that are underserved. Things that we advocate for as the American Academy of Family Physicians, teaching health centers, having more teaching opportunities and learning opportunities within rural areas, really putting more money in rural areas as far as their hospitals are concerned. We still have issues such as maternal and fetal mortality, especially within these communities. And we need to have more money and more investment in hospitals in these areas. So many have closed, and we need to open these doors. Our patients are really suffering, and we need to do something about the healthcare of our nation. And the only way to do that is to have a greater investment in primary care, and that's really important.
Absolutely. You bring up so many good points there. And one, as I've seen in my career, I think we are finally past the awareness aspect. You mentioned you were aware, and some of your colleagues were aware, but many were not, or they were in those, sort of denial phases of Kubler-Ross, where maybe it's there, maybe not. I really don't want to think about it. I'm just going to deny it. I think we've gotten past that in medicine, but now we're moving into the operational phase, the action phase, and really, truly, that should be the most exciting. It's also probably the more difficult portion, and it's these groups like the National Health Service Corps that are really making those things happen.
Yes, and and you were spot on. We really have to be more actionable right now. Now is the time for us to truly do something about the issues that we're having, and not put more money towards just sick care and more money towards prevention. A greater investment is definitely needed in primary care, and that's the only way. There was that study from the National Science and Engineering and Medicine NASEN report that talked about primary care being a common good, and we really need to put more emphasis in primary care.
How did you get interested in HIV? I see that you have an expertise there. Was that what you saw when you were in residency?
So, no, it was interesting. So many times we fail to realize the importance of community and what we do every day. And so as I was working in my community health center, we were seeing more and more individuals who were living with HIV who had only a few places that they can go and get care. And so we started providing care, and it was a learning experience, trying, because the education around HIV at that time was, really, I would say, very complicated. And so you would get just a little bit of knowledge, but not enough to really feel comfortable caring for individuals living with HIV. The medications were vast, and now we have huge, what I would say, a plethora of medications for every condition now. But it was a little bit seemed to be more for the infectious disease specialists and not necessarily for those family physician specialists, although there were some out there, and I learned from some that were providing the care. But the gist of it is we needed someone to care for the increased number of patients that we were seeing that were living with HIV. And so I took on that challenge. And our organization that I was working with decided to become a Ryan White grantee. And, I just had to keep learning. And then I realized how important it was to, be the best that I can be and get credentialed as a HIV specialist. And then, it was the needs of the community that really drove me to HIV. And I am just so thankful that it did, because having that impact in the community, I now provide gender affirming care because, again, it was the needs of the community, the individuals that we were seeing that were living with HIV that were not into care because they were missing that opportunity to get their gender affirming therapies. And so, just meeting the needs of the community is really important. It's an important thing for us as physicians, and recognizing that, you need to meet your patients where they are. You need to be part of the community, and that way you're able to be trusted, especially as we're dealing with many things such as, COVID-19, and being that trusted resource for our patients. And the only way for one to trust you is, for you to be part of that community. And so it was really important for me to do that.
We talk about family medicine physician. Let's back up a little bit and explain to the audience. Some people know, but they don't really get exposure to understanding what the difference is between, and what the similarities are between, a family medicine physician, internal medicine physician, and then some older terms like general practitioner, and then a term that's more all-encompassing like primary care. So maybe just let the audience know about those different specialties.
Yes. So, primary care, I would say, is the umbrella of, family medicine, internal medicine, pediatrics, and many others. But the difference between family medicine and internal medicine is that we specialize in the care of individuals from birth all the way through death. We also can deliver. I still see kids and now young adults that I delivered during residency in my practice. So seeing that full lifespan of individuals is what a family doctor does, in addition to prevention, caring for individuals comprehensively, acute care, chronic care. Internal medicine, pediatrics usually focuses on that particular age group. Internal medicine is usually those individuals, like some see them as young as 16, but mostly 18 and over. And of course, pediatrics, the newborns on up. But we do the full spectrum, and, family physicians, we can serve in, and we're trained to serve in any area in the hospital, in the clinics. Many other specialties, they focus in on different areas. We do the full gamut. We can be in the ER one day and in the clinic and doing surgeries, minor surgeries the next day. We do, some of us do colonoscopies. One of my colleagues, I was just talking to them just the other day, they're trained to do colonoscopies. And, so there is so much that a family physician can do in caring, again, for the whole family. That is that the baby, and, I see some 3-4 generations of patients, and it's important to have that connection, because what that patient's genetic profile could be, what we have seen in that particular family. So it gives us that advantage. And then, now with so much going on with this pandemic and getting individuals vaccinated, we're able to talk to mom, dad, talk to them about their grandparents, uncles, aunts, their babies, and their young ones, and just, really be able to be part of that family, and then ultimately being part of that community. So hopefully that explains the difference.
Oh, no, it's a great job. And some things I think about is family is like familiarity, and familiarity is trust. And that's what you're talking about, the access and then the trust between the patient and the physician and the family as a whole unit. And I know I will get the question, because I have before, therefore, is there a competition between internists and family medicine and pediatrics? And the answer is no, with very rare exception, and maybe certain parts of the country. Most doctors practice for their patients and with their colleagues. We utilize each other. I'm an emergency medicine physician, so I'm definitely speaking with a family medicine physician who also calls me about questions on acute care, and that's how we operate. So then someone says, well, there's overlap there. Is that inefficient? And the answer is no, because all of those primary care specialties are needed. Tell us a little bit about your perspective, and I'm just kind of throwing this out there, on the differences in urban and rural medicine as far as access. There is a little misconception that rural has less access. That's not necessarily the case, but they are different.
Yes, they are different. And, I work in some urban areas, and have worked in urban areas that are just as lacking of access that a rural area is. Transportation, not being able to, if a bus that you can get on to get from point A to point B is going to take 2 hours, then that is not efficient. And so those are issues that we see that are similar. Lack of transportation within rural areas and urban areas is a problem. But, there may be more things available within rural, but then, there's still issues, trying to get to other specialists is another concern that I have with my patients. In the rural areas, trying to make an appointment to another specialty colleague it's almost impossible, because my patients just can't get there. And I have that same issue in my rural office. So the issues are still there. We still have food deserts within the urban areas, trying to, if you don't have transportation to get you from, one point to another, or the money or the finances, then those issues are the same, whether you're in an urban area or a rural area. The problem is with rural areas, there may only be one doctor. And in the urban areas, you may have more, but still trying to get to those particular physicians can be difficult. So I see pretty much the same problems: access, transportation, finances, money issues, individuals not being able to take off work to get to the clinic. And, thankfully now we have telehealth that has provided another means to help with access in both the rural and the urban areas. But also we see issues with broadband, not having internet access in rural and in my urban areas that I work. So for me, it's unique, because I see both. Some days I'm in my rural clinic, and some days I'm in the urban clinic, and I see the same problems, and it's frustrating.
Yeah. Have you dealt much with trust issues? And I'm sure you have during this pandemic with your patients. And when I say trust, yes. I mean trust of vaccines, trust of recommendations, trust of regulatory agencies.
Yes, and it's really important, to have that relationship with your patients,
Absolutely.
because no matter what, if many times they will say they trust you. We even saw that there was a study that indicated that 46% of individuals would get a vaccine or get like the COVID vaccine if it was done in their physician's office. And
Right.
so, having that relationship really helps to give that patient that trust. I always sit down, I talk to my patients, I listen to them. They know that if they have any issues, they can call me. And, it's all about trust and listening and meeting your patients where they are. And that's the only way I think that I've been able, and many of us have been able to really get through getting many folks vaccinating, getting those shots into as many arms as we have been able to get. And that is through, trust and having that trusted relationship with your physician. And I tell you, I tell my patients, they are my family, and I treat them like my family, and they know that. And so when they have concerns about, what was myth and what was truth with the pandemic and with the vaccines, I was able to talk to them about those. Not always winning. Sometimes I was not successful, but again, I would tell them, you don't have to decide today, but if you have any questions, come back and we'll talk about it. I'm going to tell you, and the other thing is telling your patients how important it is that you are a partner in their health. And you're there for them and to help them to live their healthiest life, and to help them to be there for their families. And it's really tough, especially in the communities in which I serve, with individuals even being able to take some time off of work. Oh, I can't go and get this appointment done because I can't take the day off, and really trying to talk to them how important it is to do this and let us work together. How could I make this work, for you? Do I need to reschedule it? Do I need to do this? So those are things that are really important as far as being that trusted individual within your community and within your practice.
And something that I personally learned, I'd like to think I always knew this. I probably always knew it, but I really had to learn and experience early in the pandemic is acknowledging and accepting and understanding why they have those misconceptions or fears or anxiety, and how by acknowledging them and understanding where they're coming from, which is not always the same place, then you can speak to them about their trust. And like you said, maybe not today. Let's let you think about it and come back. As we close here, I want to learn a little bit more about your role, though, with the AAFP.
So, I have been honored to have been elected president of the American Academy of Family Physicians, and currently serving as board chair. It has given me the opportunity to really be an advocate for my patients, for my community, and for my specialty. We have so many things that are wrong within our country, especially, the small amount of money that we spend on healthcare and the poor outcomes that we see. Our outcomes are worse than any other high income country around it, but yet and still we spend so much money with sick care and not necessarily in prevention. And having the opportunity to be a voice for my patients, a voice for my communities and my specialty, as we continue to try to improve the healthcare of our nation. This has just been a wonderful opportunity for me, and a great journey. As I said earlier, I knew that I wanted to be a family physician from the beginning, and now it's even more evident. And as I look and I talk to younger individuals who are looking for, career choices, to talk about the importance of primary care, to talk about the importance of family medicine and the impact that we can have within the lives of our patients, and having them as part of our family is so important. It's so important.
Dr. Stewart, I want to thank you for your service in this voluntary role. Many people don't realize when you take a position like that, elected or not, it is service. It's service that you're giving back now because you feel blessed with the education and the experiences you've had. And I just want to say thank you on behalf of physicians and patients in the country. It's an important role, and you are doing a great job. So thank you.
Thank you. Thank you so very much.
And thank you for joining us on Medical Matters Weekly. I'm also going to thank Mike Cutler from CAT TV, Ray Smith from Southwestern Vermont Healthcare, Ashley Jowett from Southwestern Vermont Healthcare. I'm Trey Dobson. Go out and find joy in everything you do, even in the face of adversity. And we will see you again next week.